Assalamu alaikum. Welcome to my new medical channel. Here I will upload only the medical contents. I will focus these medical contents especially to young doctors who struggle during their early phase of preparing themselves in several postgraduate entrance exams throughout the world. So naturally, some of you already know by this time that those preparations require some funding. And to manage those funds, the young doctors struggle a lot often. They have to go through a period of depression when they can't focus on the studies because they don't have enough fund. And when they try to manage the fund, they have to work overshift sometimes, and it takes a heavy toll on them. So not too much introductory speech, I think, but I have to say these things. So I want to tell you that I feel you. I have gone through that phase in my life, and I want to help you really. And so you are not alone. Don't feel alone. Um, as long as you are not being able to go through those paid courses in any of the coaching centers or any of the mentor, I'm with you. You can follow this channel, subscribe this channel. That will motivate me. You know, I I don't get enough time to go through all the textbooks, prepare some very well arranged lectures, PowerPoints, and etc. etc. and then come up with some good presentations. Uh, and also, I don't have time. Also, I think that's not a wise approach to go every time. Rather, if I can help you go through your textbook, word by word, line by line, help you understand as much as I can. So that will be more effective. But for me, for my channel, that will not be effective. It might have some copyright issues because I'm using exact the text. So still, I can have the benefit of happiness when you learn something from me, rather with me, and then you can do well in your days ahead. So not too much talk. Let's go. Let's go through the textbooks. I will start with clinical medicine. As you can see, I have opened a textbook here, Davidson's Principles and Practice of Medicine, the latest 24th edition. And I will start with rheumatology. Because why rheumatology? I think this is a chapter that people don't focus much. People always are fancy about topics like neurology, cardiology, etc., etc. So I want to start with a neglected chapter. So we will go through this chapter, rheumatology and bone disease. And you can see a total outline of this chapter here. First, they discuss about the clinical examination of the musculoskeletal system. Then they discuss the functional anatomy and physiology. Then investigation of musculoskeletal disease. Then presenting problems in musculoskeletal disease. Some presenting problems like monoarthritis, polyarthritis, fracture, generalized musculoskeletal pain, muscle weakness, regional musculoskeletal pain. Then the principles of management, education in and the lifestyle interventions, non-pharmacological interventions, pharmacological treatment. Then we come finally to the disease itself, the very common disease of rheumatology, osteoarthritis. Then crystal-induced arthritis, we commonly know gout, and then fibromyalgia, bone and joint infections, like we know that septic arthritis, osteomyelitis, these kind of things. Rheumatoid arthritis is very common topic, but the incidence rate is not that much common. Juvenile idiopathic arthritis, spondyloarthritis, it mainly encompasses the seronegative arthritis. We will discuss about that later. What is seronegative? Axial spondyloarthritis, reactive arthritis, psoriatic arthritis, enteropathic spondyloarthritis. Then we come to autoimmune connective tissue diseases, vasculitis, diseases of the bone, osteoporosis, osteomalacia, rickets, and vitamin D deficiency. I'm going through this fast because I'm not discussing anything, just reading out the menu to you. It's important to read out the menu also, because whenever we will go through the textbook, the pages ahead, then you will have in mind that there is lot more, there is way more to go. Okay. Paget's disease of bone, the bone diseases, bone and joint tumors, rheumatological involvement in other diseases and miscellaneous conditions. Okay. So the first page, this is an overview of the clinical examination of musculoskeletal system. We can learn about the clinical examination itself from the different books of clinical methods like McLeod's clinical examination, Hutchison's clinical methods. And if we get time, we will also go through those textbooks, inshallah. So now let's come to this. Here are some bullet points about some findings of some diseases. As we have not started discussing an individual disease yet, we will just get ourselves oriented to some findings. As we can see, this is the extensor surface of a person's left elbow. I will say left elbow joint. This is the upper part of forearm. This is the lower part of arm. So this is called the extensor surface. Okay. So in extensor surface, there are some large nodular swellings. Okay. So these are rheumatoid nodules. These are rheumatoid nodules, typically found in rheumatoid arthritis patients, not all rheumatoid arthritis patients, some of them. And also, when we say that extensor surface, another disease manifests mainly on the extensor surface of different parts of the body, like psoriasis. The rashes of psoriasis typically occur on the extensor surface. Okay, so we have learned two things from here. I will review again. You can listen to me. On the extensor surface, we sometimes find some large nodular lesions in a patient with joint pain. So we will keep in mind about rheumatoid nodules. And when we said extensor surface, so we will remember that another disease manifests its lesions mainly on the extensor surface. It is psoriasis. Okay, I'm taking a lot of time in discussing this because, or so that you can memorize it very, very, very well. So I emphasize on it again. On extensor surface, we have learned that rheumatoid nodules occur and also psoriasis. Then we come down vertically. So this picture, it shows a nail. So you can see that there is some pitting of the nail. Pitting, that means some depression. Okay. So this nail pitting or nail dystrophy, this is also a feature of psoriasis. Rather, I would say psoriatic arthritis. The skin manifestations plus joint inflammation, psoriatic arthritis. Nail dystrophy is a typical finding in psoriatic arthritis. Okay. Next, synovitis and deformity in rheumatoid arthritis. So, in rheumatoid arthritis, we will learn later when we will discuss the disease that it has some predilection mainly to the small joints of the hands. Okay. Why small joints? Because they are small in size. You will see that this is the wrist. This is a large joint. Because when you compare this joint to these joints, the metacarpophalangeal joints, the interphalangeal joints, these are very small joints, and this is a large joint. So in rheumatoid arthritis, it has predilection for small joints of the hands. Okay. So we can see that the metacarpophalangeal joints are swollen, swelling is one of the cardinal features of inflammation. So this is arthritis. Okay. We will see that the interphalangeal joints, some of them are also swollen, inflamed. So we see these kind of features in rheumatoid arthritis. And also we will see later also that there are some joint deformities that occur. So when you will say the dorsum of your own hand, you will see that the fingers usually are aligned. They're straight like this, straight. But in this person, his fingers are aligned a bit obliquely. So they show some deviation. They show some deviation. So this is the ulnar bone. This is the radial bone. So we can see that the fingers are deviated towards the side of the ulna. So this is called the ulnar deviation. This is one of the deformities we typically find in long-standing rheumatoid arthritis patients. Okay. So next one. So we will see when we palpate these joints, interphalangeal joints, we will palpate and see that there are some nodes here, nodules here, not just swelling. These are nodules. Nodules in interphalangeal joints. So these are called Haberden's nodes and Bouchard's node, or you can say also Bouchard's node, whatever you say. These are typical features of osteoarthritis. So when we will study the disease itself, we will come to know about this again. And you should be able to remember this picture when we will study about Haberden's and Bouchard's node in osteoarthritis. Okay, these are typical for osteoarthritis. So let's see some more. So we can see there is a lady. Her face shows some red lesions, red, rash, and it has some typical shape. It looks like a butterfly. So it is a butterfly rash, typically seen in SLE, systemic lupus erythematosus. We will learn about this disease also later. So this is a systemic disease where typical butterfly rash is seen. Okay. So we can also understand some things because this textbook has given the picture of a lady to show finding of SLE because SLE is more common in women. And also we will see that this fold of the face, this fold here also, this is called the nasolabial fold. We will see that the rash has not reached that fold. That fold is free from any rash. It is normal color skin. So we say that in SLE we will find a butterfly rash which spares the nasolabial fold. Okay, that's good. Then when you see someone's eye or your own eye in front of the mirror, you will see that the color of your eye is absolutely white. That is the sclera of your eye. In this person, we see there is some reddish coloration, like there is some bleeding here, and also there is some discoloration here. These are also features of some inflammation. So, and which part of the body is inflamed here? The sclera of the eye. So this is called scleritis. This is also one of the systemic findings of rheumatoid arthritis. Okay. Systemic findings mean system. System means different systems of our body. In rheumatoid arthritis, mainly which system is affected? Musculoskeletal system. So that is the primary system there. So all other systems other than the musculoskeletal system in rheumatoid arthritis or any other disease affecting the joints, those are called systemic manifestations. Okay, so scleritis is one of the systemic manifestations of rheumatoid arthritis. Next, disease. This is a bony deformity where we will see that this is the knee, this is the leg, and this is the foot, and this is the thigh of a person. In the leg, we will see that there is some hypertrophy, or simply you can say that there is swelling, redness. So this is one kind of deformity, but this area is deformed. So this kind of bony deformity or bowing, convex shaped deformity, this finding is found in Paget's disease. Paget's disease. Okay, we will study about this disease also later. Now, this is also one of the typical findings. So this is, we will see that this is the left foot of a person, left foot. This is the first metatarsophalangeal joint. Okay, so and this joint is very much swollen, and this joint is red. So we have found two of the cardinal features of acute inflammation here. Acute inflammation or inflammation simply of a joint is called arthritis. So this kind of arthritis typically affects the first MTP joint or first metatarsophalangeal joint. So which disease typically involves the first metatarsophalangeal joint? This is acute gout. If I have enough time, I want to say this 10 times in front of you so that you remember this information for the lifetime, because it is very much important. So this is important for your exams. This is important for your clinical practice later in life. So the most common joint to be involved in acute gout is first metatarsophalangeal joint. So we are done with this page, an overview of clinical examination of the musculoskeletal system. I want to very quickly review this page again because it has some important informations. We have seen that rheumatoid nodules typically occur in the extensor surface, and also psoriatic rash occur in the extensor surface of the body. Nail dystrophy found in psoriasis or psoriatic arthritis. This is a ulnar deviation or deformity seen in rheumatoid arthritis patients. These are some nodes, Haberden's nodes and Boucher's nodes seen in osteoarthritis patients. And then typical butterfly rash, which spares the nasolabial fold, seen in SLE, occurs more commonly in women. Okay. Scleritis, one of the systemic features in rheumatoid arthritis. Then a leg deformity seen in Paget's disease. And then typical metatarsophalangeal joint, first metatarsophalangeal joint inflammation seen in acute gout. Then we come to the next page. This is another part of the clinical examination of musculoskeletal system. I will not go through this part very elaborately because this is not that much informative. This one page, we have to study the clinical methods or clinical examination books for this information. But I like to say some words about this test. This is called Schober's test. This pronunciation is Schober's test. So this is the back of a patient, back of a person. Here we mark skin with pen in midline, about 4 centimeter below superior iliac crest. Here we will find the posterior superior iliac crest and also here posterior superior iliac crest. So 4 centimeter below that level, we will mark with the pen. Make another mark in midline 10 centimeter above first. So this mark we have made with a pen, and then 10 centimeter above this, we will have another mark with the pen. Okay. Then we will ask the patient to bend forwards up to, he will touch his toes. He will touch his toes. That means the finger of legs. toes. Then normally when he bends and touches his toes, the distance between these two marks increases at least 5 centimeters. So here the distance is normally 10 centimeter. I put 2 marks here. When he bends, there will be an increase in the distance between these 2 marks at least up to 5 centimeter. Okay. So if the distance does not increase up to that level, then we will think that the joint movement, intervertebral joint movement, is not normal. So this test, Chopper's test, has this clinical significance. We will study this better in clinical methods books. So next page, the functional anatomy and physiology. I have highlighted the important words, important lines that are necessary here. So we will mainly focus on that. So it says bones fall into two main types based on their embryonic development. And so according to development, bones are mainly two types, flat bones and long bones. So flat bones. Flat bones, they develop by intramembranous ossification. So they develop from an embryonic membrane, intramembranous ossification. And then long bones. Long bones develop by endochondral ossification. Chondral means cartilage. So long bones develop from embryonic cartilage. Okay. So I will say it again. In respect to development, bones are divided into two types, flat bones and long bones. Flat bones have membranous ossification, intramembranous ossification, and long bones have endochondral ossification. Okay. So next. Next, I want to read from this line. A thin remnant of cartilage called the growth plate or epiphysis remains at each end of long bones. So if we see here, if this is a long bone, it has two ends. This is the upper end and this is the lower end. So in each end of the bone, there is a thin plate of cartilage. Thin plate of cartilage. Here and also here. So that thin plate of cartilage is called epiphysis or epiphyseal plate or growth plate, because the growth of the bone occurs from here. Okay, that's it. That's it. We are done. So come again. A thin remnant of cartilage called the growth plate or epiphysis remains at each end of the long bones, and chondrocyte proliferation here is responsible for skeletal growth during childhood and adolescence. So you can understand that in this growth plate, there are some cartilages, and the cells of cartilage are called chondrocytes. Okay, chondrocytes are here. They grow from here during childhood and adolescence. At the end of puberty, the growth plate fuses with the compact bone. So no more growth occurs after that. So why does it fuse? Here it is written, at the end of puberty, the increased levels of sex hormones, that means testosterone in case of males and estrogens in case of females. These sex hormones halt cell division in the growth plate. So testosterone and estrogen are responsible for halting the cell division of chondrocytes in the growth plate. Okay. You will see that in your exams, any exams in the world, the examiners will not just copy the lines of the book, they will write the question in their own language, but the theme will be the same. So you will have to remember the theme, not just memorize the line. Okay. Okay. The next line, the cartilage remnant then disappears as the epiphysis fuses and longitudinal bone growth ceases. Okay, I have already said that. And then let's come here. Two types of bone tissue are present in the normal skeleton. They are the cortical bone and the trabecular or cancellous bone. So we have studied about types of bone earlier here. That was the developmental classification. According to development, those bones that develop from the embryological membrane are called intramembranous ossification. They are called flat bones. And those bones that develop from cartilage, embryonic cartilage, are called long bones. So endochondral ossification. And here we are getting familiar to another type of classification of bones. These are cortical bones, and another one is trabecular or cancellous bone. Cortical bone is formed from Haversian systems, comprising concentric lamella of bone tissue surrounding a central canal that contains blood vessels. So let's just finish the next line. Cortical bone is dense and forms a hard envelope around the long bones. So I will tell you to focus on one word first. Cortical bones, mainly hard bones. This word, hard bones. That means compact bones. Inside the cortical bones, when we have a transverse section of a cortical bone, let me draw something. Okay. I have just drawn a long bone. If we cut this bone transversely, we can see like this, a view like this. So we will see that this bone is composed of some different units. There are central canals, canal-like things, and they are also attached one with one another. And there are some circular rims like this. They are called lamella, like this. These are called lacunae, and they are all together called the Haversian system. We will know more accurately about them in histology if we come to study about that. So let's stop this now. Haversian system. So we were studying about compact bones. Compact bones have Haversian systems inside them. Compact bones are hard. Okay. Lots of you know more than me about the topic. I know that. But I want to focus the ones who are absolutely fresh or who have a long study gap after their graduation, after their medical graduation, who lack in confidence. So I want to start from the scratch with you. Stay with me. If you feel boring, you can leave the class. You can listen to the class later. Okay. So let's come here. Cortical bone. This is a hard bone. This consists of Haversian system inside this. And then trabecular or cancellous bone. So these trabecular or cancellous bone, these kind of bones stay in the center of the bone. Center here. In the periphery, there are compact bones or cortical bones. We will know that anything, cortex of any organ means the periphery of any organ. Cortex. Okay. So in the cortex, we will find cortical bone or compact or hard bone, which consist of Haversian systems, and in the center of the bone, we have trabecular or cancellous bone in the center. Okay. Now, next topic is important. Important cell types in bone. What type of cells are there in bone? So the cells are osteoblast. I will start with osteoblast, and then osteocyte, and then osteoclast. So osteoblast, blast, they contribute in bone formation. Osteoblast, they are immature bone cells. They contribute in forming mature bone cells, which are called osteocytes. Okay, so here it is written that osteocytes are the cells that differentiate from osteoblast. Differentiate means originate from the osteoblast. Okay, and then osteoblast, here it is called that these are mononuclear cells derived from marrow stromal cells. This information is not that important. You will always have to keep it simple. And then osteoclast, this is important. Osteoclast, this is a bone destroying cell. It causes bone resorption. Resorption means destruction. It causes decay of the bone. Okay, osteoclasts are macrophages like cells. Macrophage like cell. They are multinucleated cells. We will have to remember that also. In some examinations where they will say that which of the following is a multinucleated cell, or they will just write a stem that which of the following is true or which of the following is not true. So there it may write that osteoclasts have several nuclei in their cells. So that will be true. Several nuclei means multinucleated cells. So osteoblast, osteocyte, and osteoclast. These are the three types of cells inside a bone. So osteoblast, these are mainly progenitors. These are mainly embryonic cell. They divide continuously and form osteocyte or mature bone cell. And osteoclasts are multinucleated and they help in bone destruction or bone resorption. Okay. Now, here, this information is important. This information is about osteocyte. Osteocytes are important for coordinating osteoclast and osteoblast activity. Activity of osteoclast, bone destruction. Activity of osteoblast, bone formation. So osteocytes coordinate these two functions. Okay. How it coordinates? The osteocytes produce receptor activator of nuclear factor kappa B ligand. So this full name, we don't need to remember the full name. We just have to remember the abbreviated form, RANKL. RANKL, receptor activator of nuclear factor kappa B ligand. Okay, and sclerostin. Osteocytes produce these two substances, RANKL and sclerostin. Why does it produce that? Because it wants to coordinate the functions of osteoblast and osteoclast. Okay, so we will have to remember RANKL and sclerostin. Sclerostin, also the full name and abbreviated form SOST. So then we come to bone marrow stromal cells. They also produce RANKL like osteocyte, and bone marrow stromal cells produce MCSF, macrophage colony stimulating factor. And this RANKL and macrophage colony stimulating factor together, they act to stimulate the function of osteoclast formation. So let me ask you one question. If RANKL and macrophage colony stimulating factor stimulate osteoclast formation, which will be the end result? It will be bone resorption. So in other words, RANKL and MCSF help in bone resorption. This is a very, very, very important information I have given. Very important information. So I'm putting a star mark here. So RANKL produced by both osteocytes and bone marrow stromal cells. It causes bone resorption. Macrophage colony stimulating factor. It also causes bone resorption. And then Bone lining cells, we don't have to go through that part. It's not that much important. So we'll come down. You see, this is the peripheral part of a bone, and when we cut section this, we see this. This is the cortical bone, transverse section or cut section, and in this cortical bone, we'll see that Haversian systems are here. These longitudinal components are Haversian system. In Haversian system, this is a central circular thing, and a canal comes down from here inside. This is called the central canal. Inside the central canal, there are blood vessels, arteries, and veins. Okay. And these circles, these are called concentric lamella. And this lamella consist of collagen. Okay. In these lamella, we see this some insect-like cells. These are osteocytes, mature bone cells, osteocytes in the Haversian system. So this is a very beautiful picture. And in this picture, you see that lots of nuclei here in this cell and multinucleated cell. So which multinucleated cell we talked about earlier? Osteoclast. This is written here, osteoclast. So you answer me, osteoclast cause bone formation, true or false? It's obviously false. Osteoclast cause bone resorption or bone destruction. Okay. These are osteoblast or bone forming cells, osteoblast. And these are mature bone cells, osteocytes. This picture is also beautiful. Osteoblast, osteocyte, and osteoclast. Okay. This serial I told you about that, osteoblast, osteocyte, and osteoclast. Okay, next page. We will start from the next page in the next lecture. So as it is the first one, I will stop this right here, and I invite you to follow the next lectures, subsequent videos. We didn't study that much in this section, in this lecture. We had lots of introductory talks and then a little bit study. This is about ice breaking, something like ice breaking. So if you liked my intent, I will say, this has not been that much of a class. If you like my intent, my intention, why I want to share my medical knowledge with you, please subscribe my channel. This channel will not provide me any kind of money because I might face some copyright issues as I am just opening directly the textbooks. And I request you to subscribe this channel, and also I have some other channels where I share non-medical contents. If you subscribe those channels, view my contents that you feel interested to watch, so it will help me. And if you go through my subsequent lectures, it will help you immensely. I guarantee that, inshallah. So advanced invitation for my next lecture on rheumatology, the second lecture, rheumatology 2. So till then, bye bye. Allah Hafiz.